There's a phone call that takes less than 2 minutes to make, and that can legally reduce your medical bill by 40 to 70%. Not through negotiation tactics that require skill or leverage, not through an attorney or a medical billing advocate who will charge you a percentage of the savings. Through a federal law that requires every hospital in America to publish the actual cost of every procedure they perform and to offer financial assistance programs to patients who ask for them. The number on the bill sitting on your kitchen table is not your price. It is the chargemaster rate, a number that was never designed to be paid by an actual patient. It was designed to be submitted to an insurance company as an opening bid in a negotiation that happens entirely without you. Your job, the thing the billing department prays you never do, is to pick up the phone and ask 4 specific words that trigger a legal obligation they cannot refuse. The American hospital industry generates over $1 trillion in annual revenue. The chargemaster, the internal price list that every hospital is required by federal law to publish, contains prices that are routinely 200 to 500% above what Medicare reimburses for the same procedure. The difference between what an uninsured patient is billed and what the hospital actually accepts from insurance companies or Medicare for the identical service can be 40, 50, or 70%. The hospital knows this. Your insurer knows this. Your doctor knows this. And until you ask, no one is obligated to tell you that the price on your bill was never the real price to begin with. Welcome to the Invisible Ledger. If these stories matter to you, hit subscribe and the bell. This is where we trace the money they told you not to follow. The chargemaster is the hospital's internal master price list, a document that contains the prices the hospital has assigned to every procedure, service, medication, device, and supply item it provides. These prices are not based on cost. They are not based on market comparables. They are based on a system that evolved over decades of negotiation with insurance companies, where hospitals set artificially high prices to have room to negotiate downward and still land at a profitable rate. The chargemaster price for a procedure might be $10,000. Medicare might reimburse $2,000. A private insurer with a large patient volume might have negotiated a contract paying $4,000. And the uninsured patient who receives the bill is charged the full $10,000, which is the price no sophisticated payer ever actually pays. The legal framework requiring transparency about these prices was established in stages. The Affordable Care Act of 2010, in Section 2718, required hospitals to make their chargemaster rates available to the public. Initially, many hospitals complied by posting dense spreadsheets containing thousands of codes and prices in formats that were essentially unreadable to anyone without medical billing expertise. A 2019 rule from the Centers for Medicare and Medicaid Services, effective January 1st, 2021, significantly strengthened the requirement. Hospitals are now required to post machine-readable files containing all standard charges for all items and services, as well as consumer-friendly displays of at least 300 shoppable services in a format that patients can actually use. The CMS price transparency rule also requires hospitals to post payer-specific negotiated rates, meaning the actual prices they accept from different insurance companies. Non-compliant hospitals face civil monetary penalties of up to $2 million per year. Before I go further, this video is just the surface. Inside the Invisible Ledger Vault, you will find the complete hospital billing negotiation script, the Charity Care Application Guide, the CPT code lookup tutorial, the CMS Hospital Price Transparency Database link, and the state-specific financial assistance mandate reference chart. The link is in the description. But stay right here. Beyond price transparency, federal and state laws require hospitals to offer financial assistance programs to qualifying patients. Section 501R of the Internal Revenue Code, which applies to nonprofit hospitals that make up the majority of American hospital systems, requires these hospitals to have a written financial assistance policy, to make that policy widely available, to provide free or discounted care to patients who qualify based on income, and to limit charges to patients who qualify for assistance to no more than the amount generally billed to Medicare or Medicaid. The generally billed standard is critical. It means a qualifying patient cannot be charged more than what Medicare or Medicaid pays for the same service. On a $10,000 chargemaster bill, the Medicare rate might be $2,000. A qualifying patient under Section 501R can legally be limited to that $2,000 rate or less. The charity care threshold for most nonprofit hospitals is set at 2 to 3 times the federal poverty level. The federal poverty level for a single individual in 2024 is $15,660. A single individual earning up to $46,980, 3 times the poverty level, may qualify for full or partial charity care at many hospital systems. A family of 4 with income below approximately $47,000 qualifies for full charity care at most participating hospitals. These numbers cover a substantial portion of the American population, but the programs are only available to patients who apply, and most patients never apply because they do not know the programs exist. The CPT code, which stands for Current Procedural Terminology, is the standardized medical billing code assigned to every medical procedure performed in the United States. These codes are maintained by the American Medical Association and are used by every hospital, physician practice, and insurance company to identify and price services. When you receive a medical bill, the procedures performed should be listed by CPT code alongside the charged amount. If the codes are not on your bill, you have the right to request an itemized statement that includes them. With the CPT code for your procedure, you can look up the Medicare reimbursement rate for that code using the CMS Physician Fee Schedule Search tool available on CMS.gov. The Medicare rate is the floor of what a hospital can charge a qualifying financial assistance patient. It is often 40 to 70% below the chargemaster rate. If you have made it this far, you already understand the pricing architecture of the American hospital system better than 99% of patients who receive bills and pay them without question. Subscribe and share this video. Here's the exact script for the 2-minute phone call. You call the hospital's billing department, not a general number. Ask specifically for the financial assistance or charity care department or the billing department supervisor. When connected, you say the following. Hello, I received a bill for services at your facility on the following date, and I am calling to discuss my options. I would like to request an application for your financial assistance program under your Section 501R policy. I would also like to request an itemized statement of my bill, including all CPT codes. Additionally, I am interested in understanding what your facility charges Medicare for the procedure listed under CPT code and whether that rate is available to self-pay patients. Thank you. That is the call. Those sentences trigger 3 separate legal obligations. The hospital must provide the financial assistance application. The hospital must provide the itemized statement with CPT codes. And because the hospital has publicly committed to its financial assistance policy and its charge limitation to qualified patients, the billing representative you're speaking with now knows you understand the system. In many cases, the representative will immediately begin discussing discounts without waiting for the formal application to be completed. Now let me give you the exact steps. Step 1. Request your itemized bill with CPT codes if you have not already received one. Every patient has the right to a detailed itemized statement. This is not negotiable. Step 2. Look up the Medicare reimbursement rate for your procedure using the CMS Fee Schedule Search at CMS.gov. This is the publicly available rate and your negotiating floor. Step 3. Call the billing department and request the financial assistance application. Even if you believe you may not qualify based on income, apply anyway. Many hospitals have sliding scale programs and negotiated prompt pay discounts that go beyond the income-based charity care threshold. Step 4. If your income does not qualify for charity care, ask specifically about the self-pay discount rate. Most hospitals offer a prompt pay discount to uninsured patients who pay at the time of service or within 30 days. These discounts typically range from 20 to 40% and are separate from charity care. Step 5. Ask if the hospital will accept the Medicare rate as payment in full for your procedure. Reference your CPT code and the CMS rate. Some hospitals, particularly those that want to resolve the account quickly, will accept this. Step 6. If the balance is still unaffordable after all discounts, negotiate a payment plan. Hospitals cannot report medical debt to credit bureaus for at least 1 year under a 2022 change by the 3 major bureaus, and many hospitals have internal policies against reporting medical debt at all for patients in financial hardship. I need to be honest with you, this process has real limitations. First, the financial assistance programs at for-profit hospitals are not subject to the same Section 501R requirements as nonprofit hospitals. For profit, hospital systems may have less generous assistance policies and less legal obligation to provide discounts. Second, qualifying for charity care based on income may require documentation, including tax returns, pay stubs, and bank statements. The application process can take weeks, and the bill is not paused unless you request it. Third, the negotiated rate with Medicare is not automatically available to all patients at all hospitals. Some hospitals will not extend Medicare rates to self-pay patients and are not legally required to, unless the patient qualifies for financial assistance under their written policy. Fourth, billing errors are common in hospital bills, and reviewing the itemized statement with CPT codes may reveal charges for services not received, duplicate charges, or upcoded procedures. Disputing these errors is a separate process from negotiating financial assistance, and both should be pursued. Fifth, medical debt that is not resolved can be sold to debt collectors who are subject to the same FDCPA rules discussed in earlier videos of this channel. If your account goes to collections, your rights under the FDCPA apply in addition to any hospital financial assistance you may still be eligible to request. Your grandparents paid their doctor in cash by the visit at prices the doctor set based on what the community could afford. The local hospital ran on donations and community support. The price was the price, and everyone in town paid the same one. Then one generation built a system of insurer negotiations, charge master fiction, and price opacity so complex that a routine appendectomy generates a bill with 17 separate line items billed at prices no one in the transaction actually expects to collect. There was not a more honest system. There was just a smaller one, where the doctor looked at you and set a price based on what the service was actually worth. The 2-minute phone call does not restore that system. But it lets you ask the question that system was designed to prevent. What does this actually cost? Subscribe and share this video. Every share puts the CPT code lookup in front of someone who's about to pay a bill they were never supposed to pay in full. The next vault opens soon, and what is inside will show you an IRS rule that actually pays you money every year for investments that lost value.